Now we will come to the questions. As you have seen, CARs and gene therapy is growing rapidly, even probably in the coming few years, more than mobile phones. So I have a couple of questions. We'll start with Dr. Arkin. The first question, does BCL11 modification in the is the only promising gene editing for hemoglobinopathies, or there are many promising targets other than BCL11?
Yes, can you hear me? Can you hear me?
Yes, yes, go ahead, please.
Okay, good. I think I tried to sort of allude to that during the talk, that there are other targets. Right now, BCL11A is sort of the furthest along in terms of the gene editing, either the enhancer or the binding site, the promoter, which will come, I think, into clinical trials. Certainly, there's still a role for lentiviral globin addition, although there's some concern with the latest hold. There may be additional targets that could be exploited, perhaps LRF, although it may have some cellular consequences. And the other is still the question about homologous repair, and there's correction of the actual specific mutation. The frequency for that is still somewhat challenging. I think for sickle, obviously one has to fix only one mutation. In talking about thalassemia, you'd have many different mutations. You have to do a correction for each one. I think the attractive feature of reactivating hemoglobin F is that it basically is an approach to the therapy of all the hemoglobinopathies and all the different mutations in thalassemia. So it is sort of a one-stop approach to the problem. But I think it's a fast-moving field, and we'll see whether there are additional targets.
Thank you. Same thing. Do you think this technology will be available soon as a standard of care treatment for such patients?
Well, the technology is still in the early trial phase. I think hopefully there'll be enough experience to approve some of these therapies, but because they're really resource intensive, they involve taking the mobilizing stem progenitor cells, modifying them, and reintroducing them to preconditioned patients, which is essentially bone marrow transplant. It will still be a procedure that's really for high resource environments and hospitals. So it won't solve the burden of disease by any means, and it will take a while to really make it to many different areas.
Thank you so much. I have the next question for Dr. Passy. What was the failure rate in gene therapy trials in both hemophilias A and B? And was there any specific reason for those failures?
Okay, so it depends what you define as failure rate. I mean, you could define failure as failure to meet the sort of original trial target, or you could define it as failure to produce any clotting factor at all, or thirdly, failure in terms of factor is expressed, and then due to an immune response, typically CTL against the liver, you lose all your clotting factor expression. So I'm going to just sort of try and touch on those as we go through. The first thing to say is there is huge variability in the response in gene therapy. So we can see, tenfold variation, if not more, between expression levels. The actual rate of patients not responding at all is a bit difficult to judge from the phase 1 and 2s, but it might come out more from the phase 3. And if you look at the BioMar in preliminary data at the JP Morgan, you can see that there were a number there. There weren't any in the uniQure study, but there were patients that expressed in both these at quite low levels. So as I say, it depends how you define it. What your question though is exceptionally important, because outside the context of a clinical trial, when these therapies become potentially commercialized, the rate of failure, the degree of reliability that you're going to deliver a clotting factor level that means something, that's going to deliver some impact for you, is going to be hugely important to patients. Because if you've got a arguably 10% rate of it not going to work at all, then are you prepared to take that risk? Because gene therapies with AAV are a one-off. Once you've had one, you're not going to get it again. And once you've had one person's gene therapy, you're not going to be eligible to anybody else's, because there's such a high level of cross-reactivity between the antibody response once it's been expressed. So it's a phenomenally important question. That's been a very long-winded answer to say that we don't actually have the figures yet. But is it a critical question? Without a doubt.
Come in with a question for Ruben. Ruben, thank you very much for your talk on the transplant. So if I can ask you, so also obviously encouraging results for the allogeneic trials. Moving forward, I mean, what other technologies do you think are going to come? What are the most likely things that are going to happen in the allogeneic field to bring that survival curve up? And once that does happen, is that the death of a lot of the autologous programs?
Are you hearing me?
Yeah, thanks, Said. I think the death of autologous CARs, I don't think is going to happen for a long time yet. I think there's a lot more work that needs to be done in the off-the-shelf CAR T-cell field. But nevertheless, I think we all recognize that there are huge numbers of patients that currently are not being served by autologous CAR for a variety of different reasons. Where I see the developments happening, I think there are going to be refinements in the way in which we deliver the allogeneic CARs. So, for instance, we had no idea at the beginning of the studies what dose of alemtuzumab to give. Too high a dose, you end up with more infections. Too low a dose, you basically end up with insufficient lymphodepletion and early rejection. So getting that sweet spot, and that sweet spot was different for different patients, because in some patients you had very high CD52 disease burden, others you had low disease burden. So it was very tricky to work out the optimal lymphodepleting strategy. But I think there will be further advances made in the current trials of lymphodepletion strategies. The other developments are to do with the actual engineering of the cells themselves. This particular cell only has a TRAC knockout and CD52 knockout. I think if you knock out beta-2M and you introduce elements like HLA-G or HLI that have an inhibitory effect on NK cells, you minimize the rejection of these cells, and you may not need to give as high lymphodepletion as we are now. So I think the next generation off-the-shelf CARs will probably persist for longer, and I think that's where we might start to then see improvements in the survival. It's clearly not possible to be doing allotransplants in everyone. I mean, in the ALL context, maybe yes, but I think in other diseases like lymphoma and myeloma, we're not going to want to have off-the-shelf CARs just as a bridging strategy. So I think that's where I see there being advances being made, further engineering of the cells to make them persist for longer.
Thank you very much. I'll hand over again to Dr. Ali Al-Ahmari. In case we haven't. Dr. Ali. Okay, I don't think if there aren't okay, there might be a few more questions, yes, in the chat over here. I'm going to take over. For blood criteria like dysfibrinogenemia and intrinsic factor deficiency, no, sorry. I think this might have been to another speaker. Yeah. Okay. If I can ask Dr. Stewart, I'm sorry, I'm just trying to find questions here.
I see two.
What is your opinion, Dr. Stewart Orkin, on the base editor technique? Is it as great as CRISPR-9 results in thalassemia patients?
Yeah, so base editing is certainly another new and exciting technology. It has the advantage of not involving a DNA cleavage, so it might be safer perhaps. And certainly, as I mentioned, for example, the binding site for BCL11A in the gamma promoter is a site where base editing does disrupt that site. It will be brought to trial. There is at least one company that's bringing it to trial. I'm not sure whether the efficiency yet is as good as CRISPR editing, but I think in a way this is an embarrassment of riches. We have many different approaches, many different technologies coming along, and I think the proof will have to be in really the clinical studies to see what is the relative efficiency, benefit, risk of each one of these. But I think it's certainly on the horizon.
Thank you. Another question to Dr. Passy. What was the failure rate for both the gene therapies for hemophilia 8 and 9, and what was the reason for failure?
Okay, I think I answered that question earlier. It's the same one,
sorry, my mistake.
actually. No, don't worry.
I'm having to fill in. So then I'll have to bring the question to Dr. Stewart Orkin again, which was about the role of hypomethylation. Yeah, from a genetics point of view, do you think methylation has the same influence in repressing gene expression? I don't think that one's asked.
Yes, I think this question is based on the sort of conventional wisdom or feeling that DNA methylation is inhibitory for expression of at least the gamma genes. It's really, that really comes from a correlation. It is not showing a causative chip. And our own feeling is that the methylation is a late step in silencing and really is not determining, and therefore really is not going to be a barrier in the therapies that are currently being discussed. So I think it's an interesting question, but I think it's probably a minor contributor to the process.
Thank you very much. Prof. Passy, if I can come to you with a question. Obviously, the recent reports of the malignancies have been a concern and an unfortunate sort of break to the rapid progress that we were seeing. I know this is a difficult question, but you know, the medical field and researchers are resilient. How big a setback do we think this is going to be? And what do you envisage in terms of the time it'll take for the field to get back on its feet? And I suppose this is a question to both Dr. Orkin and Dr. Passy. How do we see the field moving forward given these setbacks?
Okay, so in the haemophilia world, it's been quite an issue. It's because there's always been a concern, all gene therapies, about insertional mutagenesis and cancer. There's obviously the stuff about the neonatal mice, which has reared its head again, and insertional breaks, insertion at double-stranded breaks. So the HCC has rather ticked the anxiety boxes in many haemophilia treaters and people in the field. But it's not as straightforward as just saying, oh, this is probably linked. We don't know. The patient who developed the HCC with the haemophilia B program developed it 14 months after the treatment, which in HCC terms is probably really quite short. They were previously treated for HCV and cleared it with second-generation antiviral therapies. We don't know, more importantly, what the original genotype was, because there is quite a significant rate of HCC in patients who have been HCV sustained virological responders to treatment. And it's said that with some genotypes, like genotype 3, the risk might be as high as 10%. So the further studies on the resected material from that patient are going to be absolutely critical, and it's going to boil to, there are lots of different scenarios you could propose, but essentially, is there HCV in the clonal malignancy and has it inserted, and can you propose from where it is, if it's there, that it's likely to be relevant? So that's the bit of information I think everybody's hanging out for. There's the dog data about insertions, relatively limited but longer term, but it certainly made everybody take a big step back and then start to reevaluate, should actually we be just taking patients with this as a comorbidity? So if it isn't HCV related per se through integration, is it HCV related because of liver instability? Should we just be treating patients who've never been exposed to HCV? So it is having a big impact right across the field, haemophilia A and B, whoever's technology, but we don't have any definitive answers at the moment. How long it'll take to sort this out in terms of reassuring the treatment population, the treater group, that it's safe, I don't know. I think we'll probably have some scientific answers before that. But the other thing is that we have lots of patients that have been treated with AAV, but most of those that have had liver-directed treatment have been treated since 2015 onwards. So we've got a relatively short period of follow-up. So probably there I've given you more questions than answers to your actual one very simple question: when will we feel better about it? I don't know.
Dr. Hawken, your view?
Yeah,
When will we bounce back?
Yeah, I think my answer would be fairly similar. It's sort of like that Gartner cycle that Dr. Passy showed, that hype and disappointment, and then you come back to a plateau. I think in the case of the recent hold on the Bluebird trial with the lentiviral globin gene addition in sickle cell, it's investigations are going on now to try to figure out to what extent that was related to therapy, and if related to therapy, what aspect of therapy. What's interesting about it is that the same vector has been used in the beta thalassemia trials in Europe with really more experience and longer time, and there's been no such adverse effects like that. So one would have to propose it's either something related to sickle patients, related to a different dose of virus that may have been given if it was increased, or related to the genotype of the patients who may have been predisposed to myeloproliferative disorders, or just bad luck. I don't think we know the answer, and the lentiviruses, at least for the hematopoietic field, have been considered relatively safe, the latest generation, but obviously this is going to raise some concern. What it may do is stimulate or encourage more activity in the editing field, either CRISPR-Cas9 or base editing, if it has to do with the lentis. But of course, if it has to do with preconditioning of patients or some other aspect, then it may not, it may not free the editing field of that concern. So I think we don't know. Hopefully the hold won't be too long. Hopefully this field will be able to progress. I think it's most unfortunate that it occurred in the sickle trials, because at least in the United States, these patients have been most reluctant to participate in clinical trials given sort of historical issues. And it's just another disappointment for that disease. But I think we'll find out from additional studies. So I'm still optimistic. I think the field still will move along, but I think we need to get through this to see whether it's related to the therapy and what aspect of therapy.
Thank you so much. I think we come to the end of our session. We have enjoyed the 3 elegant talks by 3 world leader experts in their field. And I would like to thank the speakers. I would like to thank participants for joining us in these sessions. I can see now more than 4,600 attendees. So thank you so much all for joining us. And I would like to close the session and have a fruitful rest of program. Thank you so much.